name is Kristiana DeLeo, and I will be presenting the results of this systematic review of the qualitative literature on experiences of crisis care for personality disorders that I conducted collaboratively with my colleague Lucy McConaughey. Mental health crises are common experiences for people with a diagnosis of personality disorder, and research shows that there are significant public health risks, such as elevated suicide rates, extensive use of healthcare resources, and reduced life expectancy associated with PDs. While previous studies in this area have examined the qualitative literature on community care for personality disorders or crisis care specifically for borderline personality disorder, this review is the first to comprehensively synthesize the qualitative literature on service user, care, and professionals' experiences of crisis care for all personality disorder diagnoses. This review aimed to synthesize an in-depth exploration of these stakeholders' experiences, as well as their views on what is good practice in crisis care for personality disorders and what improvements could be made. We appreciate that not all studies focus specifically on PD, so we included mixed populations as long as a specified proportion of participants reported PD or related symptoms such as recurrent self-harm. Studies needed to take place in acute crisis care rather than long-term inpatient or community care, though these services could be general or specific to personality disorder. All studies must have used a recognized method of qualitative analysis to interpret their data. Studies were assessed for inclusion through a 3-stage screening process, which was conducted independently by 2 reviewers. A total of 17 papers were finally selected for the review and assessed for quality using the Joanna Briggs Institute checklist for qualitative research. We did not exclude any papers based on quality, but we did report and consider these scores in the results. We used the inductive coding method developed by Thomas and Hardin, which consists of 3 stages to thematically synthesize the data. Analysis was conducted collaboratively with researchers who are experts by both occupation and lived experience. 4 metathemes emerged from our results. First, service users and carers are met with varying degrees of acceptance or rejection when presenting to crisis care. Reasons given included limited crisis care options and resources within healthcare systems, as well as staff reluctance or refusal to engage with service users and carers. The second theme focused on interpersonal processes and dynamics at play in crisis care, including the importance of setting and negotiating boundaries in treatment, developing and maintaining therapeutic relationships, and challenging interpersonal interactions that exacerbate the presenting problems. The strategies and characteristics staff and service users employ to manage interpersonal dynamics highly influenced how the crisis care was experienced. Stigma and medical discrimination were often the source of negative attitudes from staff towards service users with PD. Staff could cultivate positive relationships by being genuinely engaged and interested in the service user, treating the service user as an individual, and being optimistic and hopeful about recovery. The third theme was managing recovery from a crisis. This theme involved the necessity of offering an integrated and clear recovery plan to service users and carers, as well as the benefits of encouraging the service user to take on more responsibility for their own care. Finally, the fourth theme involved equipping and supporting healthcare staff to provide quality care. Healthcare staff reported a massive lack of knowledge and confidence when treating mental health populations, as well as an increased incidence of feeling burned out and not given proper support. As you can see from the quote, "I feel like I'm not doing my job properly because my job is to help people and I can't help them." Staff felt as if they were not given the proper tools to be able to provide quality crisis care. Overall, most stakeholders did not have a positive experience receiving or providing crisis care, with this care doing more harm than good. Service users reported a lack of resources, stigma and discrimination, and unclear treatment and recovery plans. Carers felt rejected and excluded from the service users' care by health professionals and felt that their needs did not align with staff priorities. Healthcare staff did not feel equipped with enough training, knowledge, and emotional support to work well with this population of service users. The lack of research on crisis care for personality disorders is striking. Few studies focus specifically on PDs when evaluating emergency care, and most personality disorder diagnoses other than borderline were left out of the research entirely. Another limitation was that most of the studies that do exist come from majority white developed countries such as the UK, Australia, and USA. Future research should ideally expand on the diversity of populations studied, as well as evaluate and make comparisons between different models of crisis care, such as comparing the experience of inpatient wards to crisis houses or teams. If you have any questions, please feel free to get in touch with me or my colleague Lucy. Thank you for listening.